Welcome to AETCM, the emergency medicine channel. Sir,
Yeah.
a 56-year-old male, known case of type 2 diabetes, presented to the ER with acute onset abdominal pain and vomiting of 1 day duration. In our initial 10-second assessment, the patient was conscious and oriented, obeying commands and able to complete 1 full sentences. Coming to primary survey, airway was patent, no pooling of secretions in oral cavity, no gurgling, no hoarseness of voice. Breathing, air entry bilateral equal, respiratory rate of 20 per minute and SpO2 of 96% in room air. Coming to circulation, BP was 140/80, pulse rate of 100 beats per minute, regular. All peripheral pulses felt equally on both sides. 2 large bore IV cannulas were inserted during this time. Coming to disability, GCS of E4, V5 and M6, pupils bilaterally equally reacting to light. Coming to exposure, normal body temperature, blood sugar level was 160 mg per deciliter. He has a pain score of 5/10, for which injection paracetamol 1 gram IV stat was given.
Okay. So, 56-year-old male, sudden onset of abdominal pain, 1 day duration with multiple episodes of vomiting. Okay, so primary survey, there is no major issues in the primary survey. He had a pain score of 5/6, 5/10, and you have given paracetamol for him. Okay, you can continue with your further assessment.
Coming to adjuvants for primary survey, we have taken a VBG which show a pH of 7.4, PCO2 of 40 and bicarb of 25, indicating no acute acid-based disorders.
See, see, we are taking ABG. I am not denying the fact VBG we are taking for the patient. So, when you see a patient like this with an acute abdominal pain, why you wanted to do a blood gas at this point of time? Why you wanted to do? Should tell me a reason. What you are suspecting in your mind? Abdominal pain and vomiting. You doesn't. Why you wanted to do a blood gas? 1 day duration. Just imagine how painful it will be to take a blood gas. So already he's in pain. Why you want to do a blood gas? That is my question here. If you have something that gives me the answer, I will agree to you.
DK can present with abdominal pain.
How many DKs you have seen with abdominal pain?
Mesenteric ischemia.
Mesenteric ischemia. See, mesenteric ischemia you can tell, but what are the risk factors for mesenteric ischemia? Does he have got any risk factor? He's a diabetic patient, so DK, okay, agreeing to some extent, but again presenting with abdominal pain, vomiting, it was difficult. It can be a simple gastritis to start with, but investigation, it doesn't mean that adjuncts needed to be done. If it is indicated, you do an adjunct. If you have told me that you have done an ECG, it's more relevant that you wanted to rule out an MI. It is more relevant. Diabetic patient presenting with an epigastric discomfort, you want to rule out an MI, accepted. But getting a blood gas at this point of time doesn't need it at all. Okay, unless and until you have ruled out the common causes of acute abdominal pain and you are not finding anything major, then you are going for an blood gas, then acceptable. But otherwise you are not ruled out any of the common causes till now. So the only thing that adjunct, if needed, only you need to do. If there is no need to do any adjuncts. ECG may be sensible to get an ECG done. Otherwise, no other adjuncts, maybe a glucose random blood sugar, GRBS, that you have done already. Have you taken that? What was the GRBS value?
160.
160. So, unlikely to be DK, 160 DK. But even the patient who is on the newer euglycemic agents, like dapagliflozin. So they are all notorious to run euglycemic decay. So these are all drug the patient is on, then you can think of. But always you have to remember that you have to consider the common causes first. Then you rule out, then you are not finding out anything, then you take a blood gas. I will agree to it. But don't say that. Even if we are doing it as a part of, due to some other reason, but when people hear that you are doing a blood gas for acute abdominal pain, that doesn't really sounds good. Okay.
Then we take an ECG which shows sinus tachycardia, no STT changes. CBC CRP was sent to look for any infections, and hematocrit was also within normal limits. LFT was done and also within normal limits.
Now just see, these are all not adjuncts. The next adjunct will be your basically will be next step. You have done your primary survey, you have taken an ECG. The next step that you need to do is here assessment the patient. You have not done any history taking, you have not done any examination. Then you need it, then you seek investigation whichever is needed. So if you take in history, he said that he had some food from outside, and that is straightforward. It is a gastritis, and you can just give him some pantoprazole and he can dispose him. But you are getting any other significant history, then only you need to evaluate. So now is the time for your secondary assessment. So can you start with your sample history now? So LFT, RFT, all those investigation will come as a part of your adjuncts to the secondary survey. You have to examine the patient, basic history you have to take. He is otherwise stable, so there is a time that you can move out from the patient side and you can go to the family, or if he is able to give the history, you can take the history directly from the patient. Okay. No.
Coming to sample history, a 52-year-old male, known case of type 2 diabetes, present to the ER with abdominal pain, acute onset and continuous in nature,
Okay.
Mainly localized to the epigastric region and radiating to the back.
Okay.
The pain decreases on bending forward and increases on supine position. Vomiting, he had 5 episodes of vomiting, non-projectile, contains food particles.
Okay.
There were no other aggravating or relieving factors, no other associated symptoms. No history of any obstipation, abdominal distension. No history of any fever, no history of any even rise of temperature, loss of weight, decreased urine output.
Okay.
The patient is a chronic alcoholic, had history of binge drinking 2 days back.
Okay.
Coming to general examination.
Okay, fine. So we have got something from significant from the history. So right now we are going into a direction where we are ruling out probably we are dealing with a patient with a pancreatitis, because epigastric discomfort, the classical history of pain decreasing while stooping forward, bending forward, all those history is able to give you, and with radiation to the back. These are all classical history that you will get in pancreatitis, and one of the most important etiological factor is alcohol and gallstones. So already there is a history of binge alcohol ingestion. So again, anything has got correlation. Somebody has taken 1 peg of alcohol or 1 time alcohol, or some person is regularly taking alcohol. So can you tell what is the relationship between alcohol and pancreatitis? Any idea? So when they can develop, some people take alcohol and still they don't develop anything. So it is nothing to do with any, we cannot predict when he is going to develop a pancreatitis. We cannot predict. So maybe first time one person can develop, maybe he is taking regularly, he will not develop, but suddenly one day he can develop like this. So now this person has got a higher chance of developing further pancreatitis when he is consuming alcohol. So that is only one thing what we can say. So according to the consumption of alcohol is one of the major risk factor for pancreatitis, and epigastric discomfort, pain while bending forward with radiating to the back is a classical of pancreatitis. So if it was not pancreatitis, what will be the other differential diagnosis for you for an epigastric pain? What are the other possibilities that you need to consider?
So the most common cause will be an acute gastritis.
Okay.
Then other causes can be, we have to rule out in the ER setting, and inferior MI has to be ruled out.
Okay.
Mesenteric ischemia.
Mesenteric ischemia, epigastric discomfort. Okay.
Cholecystitis.
Then
appendicitis.
epigastric discomfort, no. So depending upon the area involved, if usually the right hypochondrium, you will have cholecystitis. Even in lung abscess can come with abdominal pain. We have to think that also. So depending upon the anatomical location of the pain, you have to consider. So usually then aortic dissection, 53-year-old male, aortic dissection, aortic aneurysm, leaking aortic aneurysm, other differential diagnosis. Then what else is there? Then you can have left iliac fossa, diverticulitis. That is the other common presentation. Just like appendicitis, they will come with acute abdominal pain, but it's in the more on the left iliac fossa. So diverticulitis is one of the most, Meckel's diverticulitis is one of the most differential diagnoses that you need to consider. Simple urinary tract infection, prostatitis, ureteric calculi. So depending upon the presentation, we have to consider regarding the differential diagnosis. So here it is more in the epigastric region, and there are risk factors for that. So you can consider pancreatitis as the first differential diagnosis for this patient. So you want to tell anything else in the sample history?
No, sir.
Ample, allergies? No. What all medication he is on?
Only for diabetes.
What he is taking?
OHS.
What OHA?
Metformin, sir.
Not metformin. So that history is again very important. So metformin, what is the problem with metformin? What is the most common problem with metformin?
Gastritis.
It can cause severe gastritis. So that is the other history. Maybe he is taking for a long time, but there has been some he is tolerating that, and suddenly it would have got exaggerated after consuming alcohol. So that is another possibility. Then they can have what is the other problem with alcohol and metformin? Liver disease. So lactate clearance there might be delayed in this group of patients who is taking metformin. So all those things you need to keep in your mind. Then any other drugs he is on?
No, sir.
No. So he developed acute abdominal pain, multiple episodes of vomiting. Now you say that I want to do a blood gas, I accept it. Okay, you are thinking in terms of an acute pancreatitis. You want to look in for what are the possibilities. When pancreatitis, how severe it is, what is the lactate level. Now there is a reason why you want to get a blood gas. Otherwise just coming in with abdominal pain doing a blood gas doesn't sound good. So we want to see whether it's a severe acute pancreatitis, what is the acid base status. All those things we can ask for, whether there is metabolic alkalosis, acidosis. All those things we can look in for. Okay, now then how will you, now we have got a suspicion of an acute pancreatitis. Now you have to make a confirmatory diagnosis for acute pancreatitis. So how will you confirm the diagnosis?
Then we go to examination.
Okay.
Examination, we can see tenderness in the epigastric region.
So clinically you can confirm, but majority of the time typical tenderness you might not able to get in pancreatitis. They are complaining of a diffuse pain. They cannot be able to pinpoint an area where, like in appendicitis, you have a McMahoney's point of tenderness. Like that in pancreatitis, it's very difficult to say. They will have a diffuse pattern, and if they have developed peritonitis, then you will have other features of peritonitis like guarding, rigidity, then all your gray Turner sign, Cullen sign, all those things you will be able to elicit. That just show hemorrhagic peritonitis. But if they don't have this thing, then you need to maybe just 1 day duration. No, it will be just an acute pancreatitis. Now, okay, continue.
Coming to general examination, the patient was moderately built and nourished, no icterus. Coming to inspection,
Icterus, why is that important?
so biliary pancreatitis.
Biliary pancreatitis, icterus. So, if the patient is having jaundice, two things you can confirm. There is either there is an obstructive component or other is a hepatic component, or hemolysis causing pancreatitis, or connection is less, but biliary pancreatitis is one thing that we consider, or there is an underlying already, there is a chronic liver disease and he is having all those issues. Okay. Coming to inspection.
Coming to inspection, the abdomen was soft, no scars, no sinuses, no visible peristalsis, hernial orifice is normal, genitalia appears to be normal, no discoloration around the umbilicus, flanks or the inguinal region. Coming to palpation, there were tenderness present in the epigastric region, no organomegaly, no guarding, no rigidity, no rebound tenderness. Coming to percussion, tympanic membrane, tympanic not observed, bowel sounds plus. Rectal examination, we were not able to done. Our clinical impression was acute pancreatitis, probably alcohol induced.
Okay, now we have gotten possibility that it is an acute pancreatitis. Now you have to confirm. You have two steps to do. Now you have to confirm the diagnosis. Then you have to grade the severity of pancreatitis. Then you need to start your management of pancreatitis. So these are the three steps that is pending. And finally, we have to find out why he developed. But here there is a high risk factor. So we can say that it is probably due to alcohol. Now investigations you can tell now. What are the investigations that you needed to confirm the diagnosis, and what are the investigations that you should send when you are suspecting a patient with pancreatitis. So you have to look in for confirmatory diagnosis and complications related to pancreatitis also. So you can just tell that.
Serum amylase and lipase.
Okay.
The serum amylase was 344 and lipase was 1200.
Okay, so if you give you one option, which one you will send? Amylase or lipase?
Lipase is more
It is
specific.
more specific. So lipase should be, you can take care of lipase. Amylase you can have other problem, parotitis, and even in pregnancy, even in any other decay and all, it can get elevated. So amylase is more not specific. Lipase is more specific. So any threefold rise from the normal is significant. Here itself 1000, more than 1000. So it's a confirmatory thing that this patient has got pancreatitis. So you have confirmed your diagnosis. Second thing, what do you have to do?
We have to look at the severity
Of pancreatitis and also complications related to pancreatitis. You can have metabolic complications, you can have local complications, you can have a complication in other organs also. So what are the metabolic complications that you need to look in for?
we had taken a CBC, CRP to look for infections, the hematocrit value for the...
Hematocrit value. Rather than you look in for infections, and this is very, very less, hematocrit is very important. Why?
severe dehydration.
Okay, so if hematocrit is somewhere around 53, 55 and all, that shows that the patient is severely dehydrated. So initially you can rely upon the hematocrit and you can keep the hematocrit to low normal, maybe somewhere around 40, less than 40, that will be your target. So you need to start hydrating the patient well. So the next thing. So you have sent for CBC, CRP. CRP, anyway, it will be inflammatory marker. It will be again elevated. So you cannot say it is an infection. It can be due to inflammation also. Next investigation. What do you want to send?
USD abdomen.
USD abdomen. Why you want to do an USD abdomen? What is the reason behind doing an USD abdomen?
To look for further complications, peripancreatic collections.
Okay. So first thing is that you can confirm that it is a pancreatitis. Anyway, lipase is elevated. You can say by doing that, okay, I am confirmed. This is a pancreatitis. Second thing, how does it help? You said the local complication, but local complication is very early to detect, like necrosis, collection formation, pseudocyst formation, and all is very, very less. But rather than one important investigation I wanted to know will be the stones. Look for any stones, any biliary obstruction, any features of IHBRD is there. That is one thing that we can do have at this point of time. If it is a gallstone pancreatitis, then that is very significant. Then you might be taking up this patient for an early ERCP. If there is no biliary obstruction or anything, we can just wait and watch. Maybe the stone would have caused an obstruction and it was just passed away. But here we are not suspecting that because we have got a clear etiology of an alcohol as a precipitating for pancreatitis. So you said regarding CBC, you said regarding ultrasound abdomen, then what will be the next investigation that you wanted?
So LFT.
LFT. In LFT, what you wanted?
We'll get the serum bilirubin levels.
What one, I am telling you, I wanted you to, only one investigation you can send. Which investigation you will choose for? You can choose either bilirubin, SGOT, SGPT or alkaline phosphatase.
Alkaline phosphatase.
Alkaline phosphatase. Again, why? Obstructive jaundice. We just wanted to initially roll out an alkaline phosphatase by looking for a features on obstruction. Chronic liver disease, we will not be able to say anything by this. Maybe an acute alcoholic hepatitis OTPT elevation we can say. But if it is a chronic liver disease, we want to do either a PTNR or an albumin level. So that is the investigation that is needed. Then, what are the other investigations that you need to look in for?
Serum calcium.
Serum calcium, very important. Why serum calcium?
Hypocalcemia due to saponification.
So at this point, what you should do, you go back to your ECG and check your QTC. So you have to check back and see the QTC. QTC is normal. Then we are not dealing with probably with the hypocalcemia. If low, again we need to correct that calcium. Then what are the investigation? So you don't see there. Just think. You have a patient in front of you. What else you wanted to know? You have confirm the diagnosis, right? Then you have to look in for metabolic complications. Now, what are the other complications of pancreatitis? A chest X-ray, a pleural effusion. 20% of the patient can have a pleural effusion, mostly left-sided pleural effusion, or they can go in for an ARDS. So right now he is stable. Right now there is no features of ARDS. Then ABG, maybe you can take an ABG. You have to look for acid-base disorder. You can look for your PO2 by FiO2 ratio and all those things at this point of time. Then renal function test. You have to look in for AKI, very common with pancreatitis, but it's very early to develop AKI. But usually in the progress of time only, they will start developing acute kidney injury. Sodium, potassium. Basic investigation, sodium, potassium. You have to look in for, because of dehydration itself, you can have hypernatremia. So you have to look in for what is the sodium level. And potassium, he had multiple episodes of vomiting. So we have to correct that potassium. So basically, the management, the investigation that you need to send to confirm your diagnosis, and you need to look in for the complications related to that. So whatever investigation that is needed, we have done. So that is the order by which you wanted to prioritize your investigation. Then what you will do right now. So you have a patient now who had come with an acute abdominal pain following an alcohol ingestion, and you have probably confirmed the diagnosis with lipase level and ultrasound level wise also we have confirmed the diagnosis of acute pancreatitis. As an ED physician, what will be your plan of care?
We will keep the patient in NPO.
We have to keep him initially for the first 24 hours. We will keep the patient on nil perorally. Then
we have to correct the dehydration, IV fluids.
Correct the dehydration, IV fluids. So again, IV fluids, you have to choose the fluid. Balanced fluid will be ideal. So balanced crystalloids will be the fluid of choice. Then next.
Antibiotics are preferred only in case if there is complications like necrosis.
That I will ask you. That time you tell me. At present, we don't need antibiotics. Clear, no? We don't need antibiotics for a regular. This patient, we don't need antibiotics. Antibiotics, what you said is right. When you are suspecting complications, or in biliary pancreatitis, we need to start on IV antibiotics. Biliary pancreatitis, some quinolones, ciprofloxacin, or any cephalosporins, we need to start. But otherwise, routine acute pancreatitis, there is no need of any IV antibiotics. Why you don't want an IV antibiotic? We are not dealing with an infection, we are dealing with an inflammation. So that is what? The next?
Pain management.
Pain management. That is very important. Pain management. What will be your drug treatment plan? One will be paracetamol, and theoretically speaking, tramadol opioids are contraindicated, but we haven't seen any problems with using tramadol for this group of patients. Pain management is the key. You can give tramadol. Previously, theoretically, meperidine was the only one drug that can be used in pancreatitis. It's hardly not available these days. You can give tramadol, but make sure that you are giving a proper antiemetic along with it. Then, calcium, sodium, potassium management. That's it. Actually, the management is only to this extent. After 24 to 48 hours, the pain subsides, the patient is tolerating oral feeds, you can start the patient on oral feeds. Only the problem is that we have to look in for complications, whether he is developing any complications. Complications as such he is developing in the lungs, any other organs. He can go into DIC, renal failure. He can have local complications like pseudocyst. You can have pancreatic abscess, pancreatic necrosis. Then only you need to think of aggravating, putting an antibiotic or all those things. So otherwise, routinely there is no role for any IV antibiotics. So now, how will you grade the severity? You have to brief the bystanders. They are waiting outside. They are asking you, how is the patient? So how will you tell them? On what perspective you will tell them, okay, this patient this is the situation.
Different classification systems are available.
What is the simple thing you can use for?
What is the patient presenting with an acute pancreatitis with a transient organ dysfunction? We can make it like a grade like moderate. But if the patient is having persistent metabolic system failure, we have to classify initially itself as severe.
Okay,
But
so
initially with no features of any extra organ involvement, that's why.
what is the bedside scoring system that you can use for? There is something called as BISAP. BISAP scoring system. It is a very simple thing. You can look for just blood urea nitrogen, altered sensorium. Then what else?
Impaired mental status. Age more than
60. Then BISAP. Huh? Pleural effusion. If the patient has got pleural effusion, so that is the simple score. If the score increases, the mortality increases. That is pretty simple. If any scoring system, the purpose is that you need to brief the patient. If somebody is coming with a high BISAP score like 2, 3, that means the probability of having a mortality is more. So you need not go and tell the patient that this BISAP is 3 and 4, but you can just prognosticate him to that extent. Usually, this doesn't look like a severe. Does it look like a severe acute pancreatitis?
No.
Then we need to, sometimes you have Ranson's criteria, you have this Apache's criteria. That time you need to send an LDH also. So that is one additional investigation that you need to send in for. But usually it is not needed these days. You can just go with our BISAP score, which is reasonable to do a bedside assessment with whether there is an altered sensorium, blood urea nitrogen level. Already investigations we have sent, and some clinical parameters also we will take in. So that is a one simple score, BISAP score, that you can use it for predicting the mortality. You should know why you are using the scoring system. There are a lot of scoring systems used in emergency room. Why you wanted to that scoring system to use? We will be all fascinated to use this scoring system when we learn, but it should have got some application. The only application that it can tell the mortality is this much. Then other one, BISAP S, I think it is systemic inflammatory response. If it is more than 2, this patient has got a higher risk factor for having an increased mortality. So basically blood urea nitrogen, altered sensorium, then age factor more than 60, pleural effusion, and SIRS criteria. Give one point to each and you predict the mortality following an acute pancreatitis. Now, there are other severity indexes, the CT severity index. So we haven't discussed anything about CT. So when you wanted to do a CT in an acute pancreatitis, that is the next question. So which patient you will ask for, okay, this patient needs a CT. The patient is in your emergency room.
In case of severe, we are suspecting severe complications.
Okay, so you can have divided like this. When you are having the patient initially admitted and later on he is not improving. So you are thinking in terms of a complication. The patient is in your ICU. You are thinking in any of these complication, whatever we have discussed, local complication, you can think of doing a CT. Then, where else you want? In the emergency room, you can just think of where else you want. You are not the
There's no clear-cut diagnosis.
you are not made a clear-cut diagnosis, like a borderline lipase elevation. You are not very sure we are dealing with a pancreatitis or we are dealing with any other surgical abdomen. For you have got any other indications to a CT, you can rule out a pancreatitis. But in generally, pancreatitis, for a confirmatory diagnosis of pancreatitis, you doesn't need a CT. So in general dictum, with our lipase level and your ultrasound, you can confirm the diagnosis of pancreatitis. Not for confirmatory purpose, but when you have other problems in between, when you have thinking of any other surgical case, like you said, you want to rule out this patient is having an atrial fibrillation also, and you want to rule out an mesenteric ischemia. Okay, then there is an indication. So otherwise, there is no indication to get done a CT. Once you do a CT, there is a CT severity index. When you get an ultrasound, you can score the severity index, whether grade 0, 1, 2, 3, like that you can divide depending upon how much involvement is there of the pancreas. So that is the reason why we wanted a CT. Otherwise, routinely we doesn't need a CT. See, when you will think of doing an ERCP? See, ERCP is one procedure, it can cause pancreatitis and it should be done in case of pancreatitis also. So when you will decide this patient needs an ERCP?
Gallstone.
Not all gallstone pancreatitis, as I told, the stone can get passed away by itself. You have admitted the patient, the jaundice is increasing. The patient pain is persistent. For the next 24 to 48 hours, there is no improvement. You are confirmed that it's a gallstone pancreatitis, then you can think of considering doing an ERCP and removing the stone. So, you have to understand that pancreatitis, once you confirm the diagnosis of pancreatitis, management is not to much extent. Only things you have to correct the hydration, you have to correct the electrolytes, and you have to treat complications if any he develops. But routine use of antibiotics is not needed at all. So don't just keep in our mind that it's not just pancreatitis, it can be something else also. So this is a straightforward patient, so it is very easy for us to do the workup and come to a diagnosis. But in a routine condition, it will be of a different scenario. The patient might be giving history of alcohol, sometimes they will not tell you, because here there was a history, we found it very easily, but they will not tell. What are the other reasons for pancreatitis? What will we suppose there is no history of alcohol here? So what are the other probabilities that you can have pancreatitis?
What is the idiopathic and any other?
Autoimmune. See, what is the most common things that we are seeing these days? Infections. So any of this infection like dengue, leptospirosis, they all can cause this pancreatitis. So most commonly the previous was mumps virus, but now any of the viral infections can, or this spirochetal infection can affect your pancreas. So pancreatitis can be an add-on feature of any of these infections. So you have to consider that pancreatitis, seeing this amylase lipase, just need not jump to the diagnosis, but you can just wait and watch. If the patient is symptomatic, you can diagnose as pancreatitis. Then hyperlipidemia, steroids, then Mr.
Paracetamol.
Okay, azathioprine. So that history is very important when you have to ask for the patient is on any immunosuppressants. Immunosuppressants, they can come with pancreatitis. So one common drug is azathioprine. Then
Any trauma,
direct trauma. Then other drug. Antiretroviral therapy drugs. That is the other group of drugs that can again precipitate pancreatitis. Then I will not stop. I am just continuing then. Because we need to keep in our mind. That is the only reason why I am asking for. Because this group of patient comes to us. OC pills. If they are on all contraceptive pills, they also can come with pancreatitis. So there are n number of risk factors. And finally, if you don't find of anything, just obesity itself can cause pancreatitis. So these are all common causes by which you can have a pancreatitis. But the most important one will be two. That is gallstone and alcohol. So you don't miss that. But it is not always that these are the reasons. Sometimes you might not find any of these causes for pancreatitis. Understood? So only thing what you have to do as an ED physician, patient coming with an acute abdominal pain, it was in the epigastric region, you had a high index of suspicion of a pancreatitis. So you did the workup along with it, so you got positive. So other thing is that just don't think that it is just pancreatitis, you looking for other reasons why he is having an acute abdominal pain. Okay. Anything else, Binu? No. Anything else you want to add on?
Yes.
Okay. So to brief, pancreatitis, the management will be pretty simple. Our thing is first confirm the diagnosis, laboratory confirmation, or by using any radiological modality. Ultrasound will be more than enough. Then you have to look in for is the complications. Investigation will be directed towards the complications. Management, hydrate the patient very well. There will be a lot of fluid loss, so you have to, just like in DKA, you need to give enough number of fluids. And next thing will be pain management, electrolyte imbalance correction. Routine use of antibiotic is not needed at all. Okay, fine.